Hotbed Talk.
Hello and welcome to EBPOM USA 2022, the value proposition of perioperative care. We are live in Charlotte, North Carolina, excited to be here in person. I'm Desiree Chappell. I'm a co-chair of our very first session. I'm joined by Saul Aronson.
Hi, Desiree. So good to be with you. This is going to be an exciting session. I'm looking forward.
Yes, it is. EBPOM USA this year is very boutique. We're a small group getting together to have really high-level conversations about the three phases of the perioperative continuum.
So today's session focuses on sort of the before, during, and after journey of perioperative care, but we're going to go deep into the value proposition.
Yeah, absolutely. Well, we have a room full of key opinion leaders, experts in the world of perioperative medicine, and our session this morning is no different. Joining us today is BobbieJean Sweitzer. Hello, BobbieJean. How are you?
Hello, Desiree. It's great to be here.
It is wonderful to be here. I love being with you on these panels and having these great discussions. BobbieJean, for those who may not know you, just tell us a little bit more about yourself.
I'm a board-certified internist and anesthesiologist, and I've been working in the perioperative space for about, too long, maybe longer than I'd like to.
We don't always have to say numbers.
25 years, give or take a few maybe. Started very young. I have been at various institutions around the country, recently relocated to Northern Virginia and working at a large multi-center quaternary care hospital system that's based right outside of DC. I am the systems director for perioperative practices there.
Yeah, and there you're really focusing in, though, more so right on the preoperative arena?
Well, I always say that, that's where I sort of started out life. But, it's really, I think that we know now more and more that if we can identify issues, make interventions in the preoperative period, we really can impact outcomes and costs really probably out to a year. I used to, as an anesthesiologist, doing pre-op, I was really happy if I could just get the patient past the day of surgery anesthesiologist
yes.
and into the operating room without their without their canceling the case or, wanting an ECG or something like that. Yeah. But now I, transitioned into, I think we need to make sure the patient has a smooth postoperative period of that was initially in the PACU. They didn't have any nausea or vomiting. They didn't have to be readmitted, stay if they weren't going to be admitted or transferred from the ambulatory center or something. And then I started looking at, length of stay and 7-day outcomes and then 30-day outcomes. And now I really, not even I was 1-year outcomes. Now I really think that the preoperative period is often one of those times when we can look at the long-term health of patients. Yeah. Increasingly, patients are bypassing all of their, other care to have surgery. In fact, if we have a chance, I'd like to tell you about a patient that I'm literally texting my team on the plane right now that I saw results of tests totally unexpected last night. And we're trying to scramble to get her care that probably won't impact her perioperative care or minimally impact it, but will make significant changes in this patient's life.
Overall life.
For not only the next few months to years, but literally her longevity and quality of life.
And hold that thought, because I think we're going to do a deep dive on those contexts.
Our other guest, our other panelists here, Dr. Chris Steele from Arkansas. Chris, thank you for joining us.
Yeah, thanks so much, Desiree.
Yeah, we've had some great conversations as well. Yeah. Chris, for everyone listening, tell us a little bit more about yourself.
Yeah, my name's Chris. I'm a board-certified anesthesiologist. I've been working in perioperative medicine since the Perioperative Surgical Home Collaborative. I was part of PSH 1.0, 2.0, and was the head of PSH 2020. We recently put out the PSH implementation guide. I chaired the committee and the work group that did that. I currently serve as the inpatient chief medical officer at White River Health System, and then I do consulting for anesthesia groups and hospital systems and quality and operations. So it's really exciting to talk about the value add here in perioperative medicine.
Yeah. Well, Saul, do you want to start us off on something?
Sure. So Bobbie, I think you really scratched the surface, and I want to kind of do a deeper dive. We talked about the preoperative period, and we talk so much about the importance of optimizing patients for their perturbation of surgery. What does optimization mean in the context of perioperative medicine? I think we just should lay some foundational sort of basis for the discussions that we're going to have. And so what does that mean? Does it mean don't cancel the case for goodness sakes, or does it mean more than that? Thoughts? BobbieJean.
I think it you can look at it from various perspectives, but, focusing primarily on the patient perspective, I think it's making sure that that patient is as well prepared for their surgery, physically, mentally, socially, as possible, to allow them to have a smooth operative, perioperative course with the least chance of complications and to meet their expectations. And so a lot of it is really trying to define what those goals are.
So I'm gonna push you on that. And Chris, I want you to jump in as well. We in the anesthesia space have been so focused on ensuring that the patient is ready for surgery by ensuring that they don't have their case postponed because of something that happened on the day of, or God forbid, canceled because of something that we realized too late in the game. But don't we have a role, I ask, to sort of touch the patient in their population health, in their more broad chronic care that we become exposed to because they happen to be having surgery? And how does that impact the optimization discussion?
I think we have a massive role, being that an anesthesiologist alone that's trying to optimize a patient the day of surgery is seen by many as an obstructionist. We're just there to cancel or delay the case. An anesthesiologist engaged in a system before the surgery to optimize the patient and keep that from happening is seen as a source of good by the surgeon, by the administration, by the patient, and by the ACO, which is involved in the continuity of care throughout the patient's entire life. And so I do think we have a role, and I think it's essential that we take part in that role.
So Chris, you touched on three targets, if you will: the patient, the surgeon, the accountable care organization, or the management entity. How do you define value? How do you define a return on the investment for optimizing the patient to those targets, be they the patient, the surgeon, or the care management organization?
Well, I think it's defined differently depending on who you're talking to. You've got to look at their vantage point. That's why I think it's essential when we talk about perioperative care that we engage all the stakeholders in perioperative care when we take care of the patient. If it's just anesthesia, I'm going to put my blinders on and I'm going to do what's important to me. And that might not be important to the surgeon, the patient, the ACO, the hospital system, nursing, or all the different care that's delivered to a patient. So I think it's important on the front end to identify the stakeholders. Let's get together and figure out, with the patient in the middle, how can we all work and make this a home run for everybody? And I think that's how you define it, because a surgeon's win is a little bit different than an anesthesiologist, and different for the PCP that's accountable for potentially the cost and the quality for that specific patient. And the patient may have a different idea from all of them. And if we don't have all of them at the table, we're going to miss the mark.
So BobbieJean, you live this every day, and you're in the foxhole. What's your pitch? What's your discussion to those key stakeholders that Chris pointed out? And do they buy it? Do they go along with your rap, if you will?
I think if I lose my license, I'm going to become a used car salesman. I try to use all kinds of psychology to bring in, to try to, get in people's heads and find out how I do get them on board with this. But I think it's, it starts out with, I think it's the right thing to do. Yeah. And it's the right thing by the patient. And I do think if we can always try to focus that on the patient and how we would want to be treated, or our families want to be treated, and how we want to build a system that offers care in the right way. I think we can stop thinking about, as the anesthesiologist or the surgeon, and not think about our competing or what separates us or how we think differently, but how we see things commonly. And I think that, bring it back to, we can do this, and I think we can do it in a cost-effective way. I think we can do it in an efficient way. I think it's a way that increasingly, many stakeholders do see the value of. And especially, patients. Patients are becoming, I think, increasingly more vocal about, that they want to be involved in decisions. And, we need to stop focusing on, certain metrics that are easy, like death or cancellations or delays or how many ECGs I did, but talk about, again, population benefits of this and, the long-term benefits of this episode of care, which we know increasingly is a very expensive episode of care. and often is what's bringing patients into the healthcare system where they haven't been before even.
Go ahead, Desiree.
Yeah, now let me just interject or ask a quick question for both of you, really. One of the things that we find when we are going, we as a broader anesthesia providers going to see how we can get into this space and be more proactive, I guess, with our patients. One of the biggest pushbacks right now is that the production pressure, volume, we have to get people through. We missed so much during COVID. We, as the hospital system and the perioperative system, don't have time to do this. Are you feeling that pushback? And what is your kind of, answer to that?
So I think if to some degree, I would say that, yes, there is a lot, but I don't know that it was, there was a lot of pressure for a long time of doing more and more cases. And I think, perhaps the bigger challenge right now is there's a shortage of healthcare providers. Yeah. There's a shortage of anesthesiologists. There's a shortage of
nurses to run all these things.
Right. So that is, a lot of the challenge, which again, in some ways kind of helps us. It's not, the blame is not on us that we're slowing things down because we're trying to optimize patients. But I will say, well, let's take advantage of that we can't do all the cases we want to do. Let's try to do the ones then the patients who don't need optimized. Yeah. So I think a lot of it's just good upfront information and triaging, and then educating folks to say, the primary care doctors need to identify these patients upfront of what, causes complications or increased complications. I just had a very good conversation with one of our geriatricians. It was a good conversation around a particular patient. We met each other. What wasn't so good about it is that she invited me to give grand rounds to their department, which I, can't say no. So I said yes, but it got no work for me. But, I think that there's just not that enough sharing that we have done with, others. I frequently, in fact, I often don't introduce myself as the anesthesiologist. Increasingly, it's more like the preoperative specialist, and I always throw in there I'm a board certified internist, because I've had literally comments just in the last week. You're an anesthesiologist. What do you care about the patient's anemia pre-op? Or why do you care about this or that or whatever? I think there's just so many misunderstandings about what the role of anesthesiologist in this space and in what we do and the value that we have. But I think it usually gets down to education and conversations. And I usually find that, I start to just sell this point. A lot of what I learned was actually from a friend of mine who's in marketing.
Yeah,
and
absolutely.
how
There's
to
lessons
market,
to be learned.
In that elevator pitch.
Yeah.
And you've got to get their attention. You've got to, show them some added value. It takes a lot of work. It takes, some partnering with literally everybody. You've got to partner with your day of surgery anesthesiologist to get them on board, so that, they don't, especially when I went into this new system, it's not strongly academic. They were very dependent on that cardiology clearance. And as long as they had the cardiology clearance on the chart, it didn't matter if it didn't have any added value to it. It was kind of like this, a checklist, or So it's, I think, educating people of the added value and identifying a group of patients, because one size doesn't fit all. We should not waste our time trying to put out this concept that every patient needs to have the same expensive, extended, complicated services, preparing them for surgery.
Yeah.
It should be very personalized.
So I'm going to challenge all of us to define value in a more quantitative way. And I also don't want to forget that the direct-to-consumer comment that you made is one that I really want to pursue. But is there data to define in a more quantitative or semi-quantitative way what we mean by value? Because the things that we are proposing we should do are things that require resources to do. And so there's always somebody in the back room who's going to be counting the beans and ask whether or not it's worth it from a more quantifiable way. What are data that exists? Are there data that exists to help us address that question?
I'd say you can define it formulaically. Value, you could say quality, patient experience, all those good things on the value equals all those good things, quality, patient experience, all that on the top, over cost on the bottom, or potentially time, because time is a very big variable there. And so as costs go up and time, bad experiences for providers, that kind of thing go up, your value goes down. Conversely, on the top of the equation, you improve quality, you improve patient experience, you improve all your outcome measures. That brings value if you hold the cost and those things the same.
So Chris, for example, to be a little bit more hard in an example, we know there's a plethora of compelling, good data that if you identify, screen, diagnose, and manage preoperative anemia preoperatively, the likelihood that you'll have a reduced chance of transfusion intra-post are greater. There's costs associated with transfusion. Do they spend preoperatively to screen, diagnose, and treat anemia justify the cost savings for transfusion, or reduction in length of stay, or reduction in readmission rate, or any of those other sort of, monetizable kinds of events? Do we have those data that we can now begin to speak to?
I'm going to say a brief part and probably kick it over to BobbieJean, who's going to probably have a lot more concrete data than me. I like to look at a more natural experiment like the BPCI, or Bundled Payment for Care Improvement Plan. What they did was take a swath of organizations across the country who voluntarily enrolled in this, and they actually allowed us to choose which procedures we targeted to improve the quality and reduce the total cost of care. And so we were able to see a natural experiment over 1 to 3 years and actually look retrospectively at it. And so we can say without a shadow of a doubt, DRG 469 and 470, which was total joint replacement of the lower extremity, was by far head and shoulders above all the other ones to actually improve quality and reduce the total cost of care when they focused on it. There were others in that didn't show that benefit. Actually, one specific one, when they focused on it, actually raised the total cost of care for that episode. And so I think we're at the very beginning of it. I think we were able to see that. I think over time, as the shift from the MIPS to the MIPS value pathway happens, they plan on sunsetting MIPS in 2027 and moving to MIPS value pathway, which is episodic care for providers or alternative payment models. We're going to be seeing more and more people that get a lot better at it. At my organization, we're a lot better at total joints than we were when we did BPCI 6 or 8 years ago. So I think as we get more experience focusing on episodes, and we're forced to by the payers, I think you're going to see more than just total joint replacement get better. But I can tell you that for sure, there's a lot of retrospective data across the entire country on that specifically. BobbieJean, any examples come to mind for you?
Yes, I think, Jerry Stonemetz from Hopkins published years ago and has continued to publish intermittently data to showing that an episode of care in a preoperative clinic where you just codify a good problem list of comorbidities that coders can then use and extract to risk adjust DRGs, allowed higher payments and higher reimbursements. And then they allowed, adjustments for things like expected length of stay, so that, for those payment systems where, those kinds of things make a difference. And increasingly, most payments are adjusted DRGs, that, this saved money. I think they showed that one study that I recently read from him, I think it was published around 2019, showed that one additional comorbidity that was documented in the preoperative clinic problem list on only 10% of a group that they looked at raised the overall reimbursement by almost 2%. So they only identified one additional comorbidity documented in the record on about 10% of patients, and that raised reimbursement by 2%.
So that's revenue generating.
Yes, so you can imagine if you magnify that, right? It also depends on who you're talking about. So, there was a pilot study from the University of Michigan of looking at ventral and incisional hernia repair. And they triaged based on, I believe it was age, smoking, and BMI, patients had a choice to either go to the regular surgeon and have a regular pre-op process or go to an optimization clinic that was staffed by a physician's assistant. That was only 0.1% of her time, so they, I think, decided that cost about $10,000. I think the overall setting up of the whole clinic process of the 1-year pilot study was less than $50,000. And they showed significant cost savings. They showed that there was a 40% RVU return of more efficiency in patients actually who were deemed appropriate and ready to go to surgery. They showed decreased complications. And one of the most striking things I thought that they showed was they identified, because it was BMI, it was one of the risk factors, they referred over 10% of the patients that they saw to their bariatric surgery program. No, they referred many more than that, but 10% of them ended up having bariatric weight reduction surgery. So it was income generating for the institution. And, you can say, well, that was just doing extra surgery that may not be beneficial for the patient. But there is such great value of bariatric weight reduction surgery. And it's estimated that I think less than 1% of appropriate patients every year get weight reduction surgery. And we've seen that, there was just a recent study showing that there was significantly lower cancer rates in patients who had bariatric surgeries, because so many of our cancers, I think about 60% of them, are secondary to obesity, or obesity significantly increases that risk. So again, you have to look at it in a bigger way. You've got to get smart accountants and smart business people, and not just, do the way, I always use the pharmacist as the example. The pharmacist doesn't want me to use Sugamidex because it costs, $2 more than it does for me to use neostigmine and glycopyrrolate. But they don't count the fact that, I can extubate the patient faster perhaps, so I'm not sitting in the OR time ticking away. Maybe I can do a whole nother case. Maybe the patient's not in the PACU longer. Maybe they don't have a post-op pulmonary complication. Maybe they don't get intubated. So we just have to count the beans.
I think that, and it doesn't seem like we've done a very good job about that in the data.
I think it's underpenetrated for sure, both in terms of recognition and implementation. But I ask, it's rhetoric, so there's no right or wrong answer, but I ask if it's revenue generating just because we have better documentation diligence, and also gives us an opportunity to understand need and be better prepared to align resources to need.
I just touched on that slice. We can talk about all the other indirect
And it also
benefits.
is cost avoidance by mitigation of otherwise adverse outcomes that would less likely occur. Are payors engaged in these realities? If they are, who is? And if they're not, why not? Chris, take it away.
Thanks. That's a really easy question. I figured it's just yes or no, but we'll dive into it. I think payers are very interested. I think, as you just alluded to, this is so many layers of depth, not just quality, different process measures, efficiency measures, structural metrics, and then cost, but not just direct cost. Is it direct cost to the patient? Is it direct cost to the payer? Is it direct cost to the system, which are all three different numbers to take into account? And so I think it is so complex that a lot of payers are starting the same way, started in fee-for-service, started adding some quality metrics to it, started pushing some episodes of their own. I think all the payers want to reduce their exposure and land in capitation at some point in time, and I think they're all working their own way there slowly. They've got to get buy-in. I think physicians and hospitals are very apprehensive of diving in. As you know, physician groups and hospitals don't have the actuarial experience of an insurance company, so there's some data asymmetry there. So we don't really trust it when the insurance company says, trust us, y'all are going to do fine. Not a lot of trust. We want money when we have it. As you know, an experiment with kids, when you offer them a piece of candy, but if they wait and don't eat the candy and you come back in 15 minutes, we'll give you 2 pieces of candy. A lot of times they eat the candy. Everyone wants proximity, time proximity. They want it when they can get it. I want to do the service. I want to make the money. If you tell me I'm going to make twice as much if I wait, most providers won't wait, and B, most patients won't wait for that delayed gratification either. So I think you got a lot of factors, a lot of fun behavioral psychology. So anyway, it's fun to talk about.
BobbieJean, in your network, are there any contract incentives that you're aware of that you can share where these behaviors are recognized and rewarded?
Which behaviors? The good behaviors are recognized and rewarded, or the bad ones?
because of the return.
Yeah. So, it's really interesting, and I work in a hybrid system, a very hybrid system that used to be, very, very much individual practitioners, private practice practitioners who just use the Inova hospitals and systems for their services. And over the last several years, it's being transitioned away from that to employed, the health system employed physicians. And there is such a big difference, It's like, because when the physicians who are salaried, right? I mean, they do work on the surgeons particularly, they have some RVU, goals that they have to hit and things like that. But I think they're just much more willing to not look at that, what's in it for me right now. Like I can do this case and I can, bill for this and I can pay my boat bill, or I can now finally get that, Tesla that I'm waiting for. But, like looking at it much more, I think from a perspective of not just money and not just what's in it for me, but from what's in it for the population, the patients that, live in our community, that individual patient, and even the health system. That, if I work for Inova Health and Inova Health stays financially healthy, then my salaried position will more likely stay in place.
Yeah. But as far as like health, like payors, I mean, private insurers, CMS, I mean, is there anyone that's actually incentivizing or going at risk?
Yeah, if I may, what I'm trying to understand, and I'm not going to beat this horse to death, but who's exposed, who reaps the reward? And are the payors recognizing the potential exposure by not doing this? And are they therefore creating incentives to help it be done?
I think they're moving in that direction. Yes. I think what, as providers, where we've run into problems in the preoperative world is anesthesia pre-op has never been as expansive as it is over the last 20 years. So we were originally, our H&P was bundled with an anesthesia. The anesthesia H&P is bundled with the fee of anesthesia. The surgeons have a 0-day global. No one anticipated this workup because no one knew the data. Now, what people are using, they're taking pages out of the primary care book and saying there is an E&M, an evaluation and management code, and advanced care planning codes that can be done in the pre-op for fee-for-service. But I do think the insurance companies are moving, and CMS in general is moving us toward the MIPS value pathway, which has total cost of an episode. There's 7 different MVPs. One's total joint, one's anesthesia. So they are pushing us to where the total cost of an episode actually reflects on me as a physician now. So they're making it salient to providers. And I believe that's a step to make pro fees really in getting away from just what do I make now, but what was the cost of care for the whole thing? Now I'm going to get to see that as a provider, and it's going to become salient. It's not going to happen year one, but as it penetrates year over year, more and more people will be like the physicians you said, and I think it'll ring that it is more than just what I'm getting now, but what can I deliver, cost and structure. And I think that's how we're seeing it. And obviously, the ACOs and advanced alternative payment models are becoming more and more prevalent to where total cost of care and the outcomes matter drastically in the viability of large organizations. So I think that's the step CMS is doing, and I feel like private insurance is lockstep with them from what I've seen.
I agree. I mean, I think it's just, healthcare is a really complex system, right? And it's so intertwined with so many different layers of competing interests. And I think that I'm surprised we've come as far as we have in many ways. But I do believe that the payers, want to really move in a different or a continued direction. I would say continued. I do think that, to be a little bit of a contrarian, I do think that the healthcare industry in the United States is really good for the economy. And I'm not exactly certain that CMS and the United States government is all that keen on actually reducing a lot of services because it employs a lot of people. And I think it's the big engine that keeps chugging along. And as long as we're, just sort of printing money at the Treasury, and we can just do that, and maybe, if the Fed can keep inflation and everything else in balance, we like to do a lot of healthcare.
We just don't have any money to do it.
We don't.
Other than the fact that we're broke. BobbieJean, you did speak earlier to direct to consumer, the patient as a stakeholder. How do you, get this story to the patient? And how do you incentivize the patient to care enough to want it, even if it means having to pay for it, because there is a return on that investment, if you will?
That is $1 million question. And I do think that we have a very health illiterate population in the United States. And even, really smart people who would spend a large amount of their time, researching and investigating the purchase of a car or something else, just sort of like show up, here I am, and they just sort of trust that the healthcare system will do the right thing and they're in the right place. And even, when we, CMS and other, AHRQ makes, information available for quality of care and outcomes, we know that the consumer doesn't look at it. The consumer doesn't seem to care. I think some of its ignorance is bliss. I think, maybe it's just too daunting for them to sort of, absorb all the information they would need to absorb when they're ill. And so much of healthcare is delivered when, an acute illness. Yeah. I go to some place because I was referred there. My, wife goes to that doctor, or I live next door to this hospital. It's not because they offer better care, or it's more cost effective. And, even, these studies that we know that, you can go, get an MRI at one institution and it may cost 10 times what the MRI right across the street costs. But consumers aren't doing that yet. And I think a lot of that is that layer of the payer, right? People have insurance or someone else is paying the bills for them. And I think if I were a payer, I would try to control costs. I think I would try to set up a different system where the patient has the out-of-pocket and it's a shared cost and it's much more of a percentage.
They become
so that they would
consumers.
That's right. They would become more consumers of their health care and not just passive recipients of what they get. And
so, Desiree, to your point, I do want to open it up to our audience participants, but I will just end by asking, again, a rhetoric question. What burden and responsibility do we have in the healthcare, industry, in the healthcare field as providers to bring along the consumer to be more invested in their own care? And how do we do that?
Well, and do I introduce myself?
Yes, please do.
So, hi, everybody. Josh Lumley, anesthesiologist from Columbus, Ohio, and North Star's Chief Quality Officer. So, this has been great. One thing, just to kind of press rewind on a point that BobbieJean made about the staffing challenges that we are having right now in the operating rooms, and really kind of rate-limiting step is, in many hospitals, is a lack of anesthesiologists and a lack of nurse anesthetists, and that is a choke point. And as an employer and a colleague, we are constantly faced with this world of, can we keep members of our team on our team? Anesthesiologists and nurse anesthetists have, tons of job offers, and they're looking at other opportunities. I think this space that we are talking about here also is a huge professional satisfier for anesthesiologists and nurse anesthetists to see, is what I am doing making a significant impact in the patients that I'm caring for, as opposed to the world that sometimes people can get into of like, I'm doing the same thing every single day. My care is really not evolving. The space that we are exploring here, I think also is a retention tool and is a tool for like broader mental health for a lot of our clinicians to say like, man, I'm being challenged every day. I'm thinking about difficult problems. My care is evolving. It's becoming much more progressive. And I know what I'm doing every day with these patients is having a very meaningful impact, BobbieJean, to what you said, like to this patient's life post-surgery. So I think the topic of conversation is amazing, but I think there is an additional value in the space of we are engaging and energizing clinicians in the care of their patients with this.
So I think you're right on. I love the comment. In the the title of the session is Perioperative Optimization. How do we define the ROI? And I think we can actually monetize what you just said, Josh. I think if I look at this in the broader context of capacity management, one of those accounting terms that we use to add and subtract numbers. But we all know taking care of healthy patients is easier than taking care of sick patients, and taking care of poorly managed sick patients is less easy than taking care of well-managed sick patients. It takes more resource. It takes more out of you on a day-to-day basis. You're physically burnt out at the end of a day where you're constantly having to work really hard with limited resources. It causes things that we define as burnout or wellness, and that translates into recruiting and retention and the costs of those events. And so I think you actually can begin to monetize the value of good preoperative optimization just from the standpoint of capacity management and recruiting and retaining. And I think there's a real good point that you raised there.
One thing I want to add to it is I think there's a big opportunity for anesthesiologists, anesthesia groups to think outside of themselves. A lot of times we're thinking, when I talk to groups, they're like, well, we can't possibly do a pre-op clinic. We can't staff. We have to say no too much. There are a lot of companies out there that will do this for you at a really high level. There is an opportunity to engage with hospitalists at your institution. Not everybody's fortunate enough to have a BobbieJean, a Mark Koch, different people that can actually do this. A lot of anesthesia groups don't. And that's okay. You don't have to be Vanderbilt or Mayo. You can be different organizations that can provide care, can be on a board to help guide the perioperative experience, and collaborate with other stakeholders like hospitalists or PCPs or other people, so you don't have to do it on your own. Or a private entity that may come in and partner with you to provide that care so you can keep doing anesthesia. Every anesthesia group's different, and I think that's an opportunity a lot of people just don't see because they're like, if I can't do it, it can't be done.
Yeah, I mean, the one point I would also say, though, Chris, is I and this is probably naive pie in the sky view here. I do think that if equipped with that sort of information, that opportunity, an external consultant comes in, someone on that team is going to have the light go off and say, I want to own this. Like, this is fun. This is, this is professionally satisfying. It's gratifying for me to do this, to know the outcome that I'm having here, and I'm growing my career. There probably are community hospitals where a person would say, yes, I'll let the consultant dictate that to me. But I do. I think you think about career longevity and passage of time. There is someone on that team that I think when they see that, external consultant or not, that comes on board, they'll say, I want to put this under my portfolio and I want to be the person that owns this at my hospital.
Yeah. Sure.
I think that is so, before she gets the microphone, I think that's so important. I think as anesthesiologists, we need to not let this opportunity go to waste.
Yeah, 100%.
Somebody said, don't waste a good crisis, right? And it's so important. We have the expertise, we have the knowledge to be the people who can bring all these different perspectives and disparate views together. And I think that is so very, very important. I was an internist before I was an anesthesiologist, and one of the reasons I did this pre-op stuff is because I realized I had no idea what I was doing. And that was years ago when you didn't need to know very much about the patient, because there wasn't even very many opportunities or anything, and nobody even talked about optimization and that kind of thing. So I'll let Dr. Edwards have the floor now.
Oh, thank you so much. I fully agree with everything that's been said. You all are doing a phenomenal job in pointing out the importance of the added value. But one thing I wanted to reiterate that someone touched on earlier, especially in the preoperative space, is that if you keep the focus on the patient, and we talk a lot about business, we talk a lot about added value, but the added value really is focusing on the patient care and what our patients currently need. And I think, those of us who are actively clinically working in the space recognize that there are certain populations that may not be able to get to us. So we have certain social determinants of health that limit institutions or healthcare systems' ability to care for these people. So adding that into our conversations, those vulnerable populations that we might not be able to reach, and what you're doing here, making things audible, making things available, and increasing the education of patients on how, and healthcare systems on how to take care of these people as they're coming for surgery or as they're preparing for their procedure is extremely important. So I think keeping the patient at the center of the conversation really is the focus of the added value piece for everything you're doing.
I agree. I would argue it's perverse. We haven't been doing this forever because it, just seems so discoordinated to a patient-centric approach. And we're all providers and we all want that. But what I'm trying to ask us to think about, Angie, in addition, not instead of, but in addition to the patient-centric sort of argument, which is laudable and important and critical, is I actually believe there is a business case to do this as well. That it just isn't the right thing to do, it's the right way to do the right thing. And I think we're not doing a great job in making that case. And unfortunately, because of that, there are hurdles, there are barriers to implementation. And I think we need to do a better job in communicating that there's a business case here too that just makes sense.
I fully agree. So that's part of the business case, is that healthcare systems and institutions are recognizing the importance of addressing these issues, these social determinants that inhibit patients to care for themselves and also inhibit our ability to get to our patients. And that is part of the business case. So I think if you add that to it, like you said, it's an added element. That is part of the value proposition.
Hey, it's Sam Ajezian from Medtronic, and I'm going to speak agnostically just as a business doctor now for the last 7 years. Saul, you're exactly right. There is a business case there, but business cases that are founded on saving us money in the hospital are much more difficult and don't often succeed as those that actually also drive revenue. And so, I'm sitting here thinking back to my days in the pediatric ICU and thinking about how do we get more revenue for the work we're already doing. Mm-hmm. It's not like we're not doing this work. We're doing it. We care. The patient's at the center. When you add that effort on top of creating a business case and going to your department chair and going to the CEO, it's not usually a game plan that works. So you really have to find partners that can help you extract more and get credit for the things that you're doing. So in the top of the hour, we're going to talk about this exact business proposition. Chris mentioned there are consultants that come in and will do your whole preoperative clinic for you. That's a great place to start with what is their business plan and how do they keep the lights on? Because if there's a business around that, then it can be your business. Mm-hmm. Yeah. And that involves that things that BobbieJean said, that you've got to have coders that understand what to put on the paper. You got to trust them. They know more than us. They know how to bill. We know what the problems are, but tying it into actually reimbursement really requires an intermediary. So, as you go through this and you discover the revenue, there are all these hurdles. You need a good elevator pitch. You got to set the hook in that C-suite. And revenue is the way to set that hook, in addition to, Josh, patient safety, throughput, metrics to retention, all the other things you've been talking about. But there is revenue opportunity there.
I agree. And, one of the things, BobbieJean, you touched on it, and we talk a lot about this, are the metrics that we need to take back. beyond revenue, for the business case, for the C-suite, and then for anesthesia and everyone else involved. Length of stay, is the one that everyone always talks about. Are we looking at the wrong metrics right now, or what are your feelings on that?
I think to some degree we are. I think we're kind of, have looked at the low-hanging fruit. It's like anesthesiologists focus too much on, PONV, or even like now, cancellation rates. Most of the time the cancellation rates are incredibly low because what do we do on the day of surgery? The patient's not optimized. Yeah, we'd rather have some other test, but we just suck it up and we don't want to be the barrier to, viewed as a barrier, so we just do the case. And so I think that, for a group of patients where, and I think as a quality metric, length of stay, but until people are really, really tying a lot of, reimbursements to that, or patients are using that as a way to walk across the street and get care somewhere else, maybe, I think that is. I think, don't forget about it, but I don't think we can stop there.
Yeah, I just feel like that there's a couple that people get so focused on. And is there other things that we can look at beyond revenue that we can use as, a building a case in this space?
My argument is the metrics depend on a lot of different factors, the type of case it is, how much you do in each organization. And so to me, one of the big things I think that's really important is a structural metric of actually what are you creating? Are you creating a water cooler for a lot of educated people to come sit down? Maybe that water cooler is the patient that we're all sitting around talking about one problem. And I think the metrics change. At our organization, it started with a readmission rate for total joints. It was over 10%. And that was awful. And we needed to fix it. That was our burning platform. And over time, it morphed into later length of stay, then pain scores. Then we got very granular as we got better. And I mean, even to measures like what percentage of people ambulate post-op day 0 after a joint. I mean, that's very granular. If we started with it, it would have been the wrong metric. So it was the right metric at the right time for us. So I think you start structurally, and then you get the water cooler conversation coming that's patient-centric, like Angie said, and then you mold that over time. And each organization is going to have different metrics.
So I love the metaphor of running the marathon. Surgery is hard. It's a perturbation that's not natural. It's an induced trauma that does a lot of things to your biology and normal physiology state. Running a marathon's not normal. Sometimes we have to confront the reality that we have to run the marathon. For most of us, that's not an easy thing to do, but we have to. And so training for it will help us be more likely to succeed in that task. How do we convince our patients that they will do better if they would be willing to train for that inevitability of having to run the marathon, if you will? And of course, sometimes we have to confront the reality that we have to have surgery. But it's not easy to have surgery. And if you train for it, you'll be more likely to have a successful outcome. How do we convince our patients it's good for them to train for their marathon? Because I don't think we're doing a good job of that right now.
Monty Ryan from University College London. So I've joined in because last week at the World Congress of Evidence-Based Perioperative Medicine in London, we had a series of presentations, mainly from the National Health Service in the UK, but also from Australia, where they've seen successful engagement of patients with regards to structured, supervised exercise programs combined with nutrition, but most importantly, they're only successful if they're combined with psychological support. So and that's been evaluated now in prospective randomized control trials and subsequent evaluations. But the psychological support was the secret sauce. And if you'd like to comment on that.
Psychologically preparing patients for that journey. And again, engaging them in that it's really, they're the ones who are going to benefit or suffer the harms of what happens. And I think a lot of this is we have just not been upfront with patients. We do not tell them in very straightforward terms that it is in their control to control their blood sugar, take their diabetic medications appropriately, and watch their calories in a period of time leading up to surgery, and give them very clear metrics. At this day, we want these blood sugars. They must all be below this level. This day we want this, and this day. You know, we're very, I think that we're very, human beings are really interesting. If things are nebulous, all right? Like, oh, you'll do better if you do this. But like, well, what do you mean I'll do better? Give them very concrete metrics. I think engage patients, educate them, and get into their heads again as to what is going to motivate them. But jokingly, the endocrinologists say that they will send, they want to send all their patients to the pre-op clinic to get their diabetes under control, because we tell the joint, particularly the joint and the spine people, we're like, okay, we're going to give you this tentative surgery date. If you meet this metric with your blood sugars by this day, that date is going to stay. If you miss that, your date is automatically going to be extended 1 week later. If you stop smoking by this date, you're going to have that surgery date. If you don't stop smoking until 10 days later, your surgery got moved back 10 days. Wow. I think, it's like dealing with children. It's like you have to be pretty, concrete and expectations. You tell them what they have to do exactly to get an A. You don't have to do any more than this, because you can't do any less than this.
It's very intimidating. I mean, as a patient, everything that someone who you feel is smarter than you is telling you to do, it's very, very intimidating. So I think bringing it down. We do have another comment from the...
So my name's Alan Kirk. I'm the Surgeon-in-Chief for the Duke Health System. You have to engage as partners, the surgeons, in convincing the patient that this is the best thing for them to do. If I sit with somebody and I say, we're going to have an operation on X date, and now here's what I need you to do, because I want you to do well. And then we go through that. They're much more likely to do that, particularly if they have a family member with them at the same time. The psychological support is all part of that. If it's, you have to go to this clinic so you can get to the OR, and that's the conversation, it's not going to happen. You also need some upstream partnership with the primary care docs, because, why are they coming to the diagnosis and the need of surgery with out of control diabetes? Why is an endocrinologist sending somebody to you with out of control diabetes? There's an issue there that has to be worked through. But I will say that partnership with the surgeons is critical for this not only to be picked up institutionally, but picked up by the patient, because I do think, not a value judgment, but the relationship between the person that's going to be doing the surgery and the patient is different than almost any other relationship that's out there. And engaging in a good script, a good way to incorporate that into the consenting process is critical for this to work.
I appreciate the comment, Alan, and I was waiting and hoping that you would speak up, because I do believe that is very true. My question, Alan, to you is, how do we do a better job in engaging that surgical component in this sort of dialogue?
What's the value proposition to you surgeon team?
Well, the most important one is your patients have fewer complications. Complications hurt. They hurt the surgeon. Nobody wants complications. And good data demonstrating that the complication rate will be lower, that the outcomes will be better, that the readmission rates and the bounce backs will be lower, is the strongest message to do that. But the other, and this is a little fluffy, but the anesthesiologists and the surgeons have to like one another. They can't be two separate groups. There has to be a relationship between those groups for this to work out. And so dialogue with the patient's important. Dialogue between the operative teams is important. And honestly, we have gotten into a point where teams are whoever shows up that day.
Yes.
So that's another problem that we own, to try to find ways to more efficiently build teams, know who is in the room with you, and then it's a partnership as opposed to like a piecemeal or widget-making operation. And that's a big problem. It's hard.
Yeah, culture.
Yeah, but if you know who's going to be helping your patient get through the operation, and you can say, I'm sending you to Saul Aronson, and here's what he's going to ask you to do, and you really need to do that. It's so much different than you need to go to a clinic and make sure you tell them you're fine, because otherwise they'll delay your surgery. Right? Yeah. The other thing to remember is that now with the problems with access to ORs because of staffing, we're now booking people out months for elective procedures. And this is the moment where there's a lot of time to work through this and not disrupt the system. So I would say, like you did, don't let a good crisis go to waste. But this is a moment where getting into the OR next week for many elective procedures is just a pipe dream. So let's use that time and build these relationships between teams and patients and their families.
I would say one way to help build those teams is to have real shared goals, right? So I think what happens a lot of times is the surgeon doesn't know what the anesthesiologist is going to expect or need, or the pre-op clinic doesn't know what and we're making it up with each individual patient. And if we could better look at the evidence is there, the best practices that's out there, and really codify, like everybody having an elective joint should be a non-smoker. So it's just, so it's not like, so the patient doesn't see this surgeon and he gives them a date if they're a smoker, or they don't come to the pre-op clinic, and we're the first ones, and they're telling them to stop smoking, and the primary care doctors know that don't refer the patient. Tell them, I'm sorry, Duke is not going to operate on your spine, your spine or your joints if you continue to smoke. So let's work on getting you to stop smoking. Good luck with engaging the primary care doctors. I think it's unfortunate, but primary care is, I don't know what's happened to it in the US, but I've always thought it was strange that we send patients back to primary care doctors to be cleared for surgery when they're the ones who sent the patient to the surgeon to begin with. Well, shouldn't they already have been cleared? And I say one thing the payers could maybe do to save money would, don't ever pay an orthopedic surgeon again to do any kind of surgery unless the patients had their screening colonoscopies every 10 years. If, that their A1Cs are, a certain number. And a lot of these are choices. We say, I know it's hard to stop smoking. I know it's hard to get your diabetes under control. But we make choices every day in what we're willing to do or not do. And if we were better, I think, in the healthcare system of holding the line on what we truly define as what quality metrics or what expectations we have for patients, I think we'd have a lot more patients get in line and want to help themselves do better.
Well,
preaching to the choir.
what a great beginning
Yes.
to a complex and long conversation. I promise for those who are listening, this won't be the end of this discussion. It's just beginning to get into it. I think we've established this preoperativization does have value. There are data that are quantifiable, both from a patient-centric lens as well as a business case lens. And where we're at now is probably figuring out how to implement it better, how to communicate that message better to the right stakeholders, albeit the patient, the provider care team that must include the surgeon, and the institutions. And we'll be back at another time, in another place, at another day to continue this discussion. But Desiree, I think it's time to sort of wrap this one up.
Wrap on our first session at EBPOM 2020 in Charlotte, North Carolina, our USA meeting. We want to thank our panel, BobbieJean, Chris, thank you so much for joining us, and everyone listening and participating today. Cheers.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.